Well, here it is. It's all about life, love, and the pursuit of happiness and going inside EMS. I am your host, Chris Cebollero, and with me is my co-host, my compadre, my friend, the Minnie Mouse to my Mickey Mouse, Kelly Grayson. KG, what's going on?
I wish you didn't make me goofy to your Mickey Mouse.
Well, I mean,
Good.
I paused, I froze. I didn't know what to do.
I'm doing good. I'm here at the New Jersey State First Aid Council conference in Hasbro Heights, New Jersey, and about to go on stage here in a little bit.
What are you teaching?
A little bit of everything. CPAP, airway management, talking about my PE and anaphylaxis, asthma, a little bit of everything.
Yeah. So how are you doing on the weight loss physical fitness journey? You look like you're trimming down every week, man. It's a new Kelly Grayson.
Lost 25 pounds in the last 6 weeks and about 45, 46 pounds overall.
Very good.
Actually, no, almost 50 pounds. I weighed 360.8 when I stepped on the scale yesterday morning, which is 4.2 pounds less than I weighed 5 days before. So
A lot of weight to be carrying there.
dropping it. Well, I'm not carrying it. I'm working real hard on not carrying it anymore. My knees are thanking me.
Well, cheers to you for doing that. And we know that it's hard. I mean, for everybody out there, I mean, we know that losing weight is hard, but you got to pick your hard. It's hard to be overweight, right? You know, having trouble in the shower, having trouble putting your socks on, having trouble. So you just got to pick your hard. Is it hard that you're getting up every day, that you're eating right, that you're doing the things you need to do to get in shape? Or is the hard that you're just going to, wear bigger clothes and find ways to get around the weight, right? So,
Diet.
you just got to pick your hard.
It's it's a good one though. It's the workouts are good. They don't pound my knees. I just get in the pool and I run as fast as I can for an hour straight without rest and check my fitness meter and it said I burned a couple thousand calories.
Yeah.
So
Yeah, I think you're putting that thing on the tire of your car when you drive.
no, I'm not. It's
Whatever, man.
about equivalent to a vigorous pool swim for an hour. Um I don't use my knees enough to make it a really good workout when I swim. I use my arms a lot, not my scissor kick and that sort of thing, but
Yeah.
it's not the workout that my knees need. So I just jog in the pool.
All right, cool, man. Well, we're gonna watch your progress over a week after week. We're gonna
Yep, yep.
be your accountability partner. So, Kelly, I had a disagreement with someone this week and talking about patient assessment. And one of the things that was the discussion was the importance of patient assessment. And I started off by saying it's the most important skill that a paramedic and EMT has. It's not your intubation skill and not your IV skills. It's your ability to assess. It's your ability to determine. It's your ability to understand for differential diagnosis. And we were talking about patient assessment, and the person was saying to me that they do not do a focused physical exam, where I was talking about that, a good head to toe survey really will help you with your differential diagnosis, because we need to be able to know that abdominal pain isn't cardiac, or cardiac pain is acid reflux, and we need to be able to assess the body from head to toe every time that we need to do an assessment for that patient. And then after the disagreement, I went back to my neutral corner and was thinking about that. I don't know, in my earlier days, that I did a full head to toe survey, and that served me just fine. So am I now being hypocritical as I'm watching newer paramedics say it's not necessary, or am I just being polished with experience to say I should have been doing this all along? So I really wanted to kind of give you that scenario that we can kind of debate, quasi discuss, or quasi debate, discuss which side is supposed to be right.
Yeah.
And I don't know that we could flip a coin to say we're going to do a focused head to toe on this patient, and then we're not going to do it on this patient. But your initial thoughts?
See, I differentiate it. I call a focused physical exam is you focus on their chief complaint and the body system and any ancillary systems that are involved, and you focus on that. You know, if a patient tells you his ankle's hurting, there's really no need to palpate his scalp and head and check his pupils and his do a cranial nerve exam. So, but that's more of a prioritizing thing. If you have a patient who is a reliable patient and can tell you what's wrong and participate in the exam, I don't think there's anything wrong with focusing on the system involved and on the chief complaint, with the caveat that that's what gets you to the truck. Once you're in the ambulance and you have the time to do a head-to-toe exam, yeah, by all means, do one. But they're on the scene when you're ready to get off the scene and start transporting. Chief complaint, the ABCs, the focused physical exam, and whatever stabilizing treatment you need to get you to the truck are just fine.
You know, one of the things that I was thinking about as part of the argument was that as an EMS chief, and there are two types of people that will call you to complain. Okay. The first type of patient will call you within the next day, which is really a customer service issue, right? This person, they treated me with disrespect. They didn't run to the house. They did. So it really is about the care that they received. The next call usually happens when they get the bill, which is a value thing to say, hey, I just got a $1,500 bill in the mail. You didn't do $1,500 worth of work on me. So when I defend the fact of saying we need to be able to give the patients we see a value for what they're going to get, isn't that the time? I mean, some of these people may not have seen a doctor in years. Isn't that a time really to say, let's go ahead and give you an assessment. Let's put you on a cardiac monitor. Let's go ahead and check your blood glucose. Or are we saying that because we have a short transport time, you're SOL?
No, I don't think so. I think it's more about what's necessary for the situation, and I genuinely don't believe that everyone needs. Now, that's a different thing, but needs has to have a full head to toe assessment. No, I think it's perfectly fine to just assess the system involved and any other ancillary systems that may be involved. You know, if a patient's complaining of chest pain, I'm going to do a pulmonary assessment as well, and vice versa, and that sort of thing. If patient's having difficulty breathing, I'm going to check them out for cardiac as well. If a patient says I'm weak and I'm hungry, I don't assume that they're just malnourished. I check their blood sugar and so on and so forth. But as far as the value thing, I'm reminded of the story about the customer that called a service tech to come out and work on their equipment, and the service tech looks for 30 seconds and says, "Oh, here we go." It takes a screwdriver out, tightens the screw, and the machine runs fine. That'll be $5,000. And he said, $5,000? You just turned the screw. And he said, well, here, I itemized the bill for you. Tightening the screw, $5, $4,995, knowing what screw to turn. And that's, I think that's a good analogy for what we do, what's necessary, what's not necessary. But like I said, there's nothing wrong with thoroughness and doing a detailed physical exam. How many times have we found something that was not necessarily benign, but wasn't the patient's chief complaint? How many times have you had your spider sense tingle and you check the blood sugar on someone, or someone mentioned what otherwise would be an innocuous set of general complaint or symptom, but in the context of what you're assessing, raises some alarm flags, and you start checking that and you find out, hey, Nancy gets on me all the time because she thinks that every single patient should get a blood sugar check. Every single patient that we encounter. And I push back against that, but I have to admit that she's kind of right. First of all, it's a cheap, easy assessment, and there are tons of undiagnosed diabetics out there. But I push back against that, or my reflexive objection to that is I see so many kids that do the shotgun assessment on everybody because they don't know how to prioritize, and their word is vomit. You know, vitals O2 monitor, IV transport, and everybody gets a 12 lead. Everybody gets a 12 lead. Everybody gets a blood sugar because they don't know when it's appropriate. And I think that's just a sign of poor training.
You think that's
But
more you think that's more shotgun paramedicine than it is just being focused in your assessment as we're being taught in school to do a full head to toe survey every time we need to.
yeah, well, and what we are taught in an assessment is not a full assessment anyway, even when we do a head to toe. EMS is called a topographical head to toe assessment, and you look at body regions. Whereas what's harder to learn, but much more thorough, is a systems assessment that a physician would do, and he checks you out by body system, neuro, integumentary, cardiac, pulmonary, musculoskeletal, so on and so forth, urinary, genitourinary, and GI, and all that. Then he checks you out and asks history questions by body system. That takes longer to do. It's much more nuanced and hard to learn, but it's also much more thorough. Uh, you know, and the other thing that I don't really like about the way we learn assessment is the notion that there's a trauma assessment and medical assessment. That's just bullshit. There's just assessment. Your assessment may change and adapt if you have a reliable patient versus an unreliable patient. But if you have you may be doing what's quote unquote a medical assessment on the trauma patient or a trauma assessment on the medical patient, depending on how much that patient can participate or not in the exam.
So maybe we switch gears a little bit. So I think we laid a little bit of the foundation of what we need, what we don't need. I think, from my argument standpoint, maybe I'm a little bit old fashioned, maybe I'm a little over. So maybe I need to change the way that I was thinking in this. And that's why I wanted to talk about it, really to kind of bounce it off and kind of talk about it out loud. But maybe we switch gears now a little bit, Kelly, because you've said a couple of things where detailed assessment versus focused assessment, and maybe we talk about some patient assessment best practices. So, one of the things that I always moved on was giving people the feeling that I was compassionate. I'm working for them right now, because people will always say, "Oh my God, I'm so sorry I had to call you." And this was, I'd say the same thing. This is your EMS system. We're working for you right now. This is your EMS system at work, kind of thing. But now when we start to think about patient assessment best practices, let's shift into that discussion and, kind of maybe share some of that expertise that we have there. But, so first, maybe differentiate when you talk about, which I think is always a challenge, is when we think about respiratory, we're going to do a cardiac workout, we're going to do an abdominal assessment, or we have a cardiac, we're going to do abdominal assessment, we're going to do respiratory. And even when you go to the doctor, I went into the doctor the other day because I was having, I had an abscess in my tooth, I had a root canal, and he listened to my heart and lungs. And I'm thinking to myself, what the heck are you doing? Why are you listening to my heart and lung? But but yeah, when you think about it, it could very well be. So, but go ahead and spit off. Let's go ahead and start that discussion.
Yeah. Alluding to your earlier statement, maybe you need to change the way you do things. I don't think so. I don't necessarily agree with your take that everyone gets a detailed physical exam, but I mean, what is the absolute worst that happens if you do it your way? The patient gets a full exam. You're not hurting the patient anyway. In fact, you're being more thorough. My only quibble is it always necessary? No, but I mean, if you gild the lily a little bit and you've done some, at the very least, you've done some good customer service, and that patient perceives some value. But best practices. I think that first of all, and a good history, and don't just budget. WNL, You know, you chart a system that says WNL, what does that mean?
Within normal limits.
We never looked. You know? And NKDA means not known, didn't ask. Uh, I can't I can't fathom the number of PCRs that I've done where I pull up the patient in our system. They're valued repeat customers. They've taken care of a million times, and the only medicine they take is UTO, which is our abbreviation for unable to obtain. You know, what's their medication list? UTO. Meanwhile, I've got a Walmart sack full of pill bottles and 3 pill minders and a list of chief complaints a mile long, and you know it's just sloppy. So don't pencil whip it. Everyone's respirations are 16 unless they're having some problems, and then you fudge that, and every blood pressure begins with the or ends with the 0. It's 120/80 or 110/70, 150/90, and you get the feeling that those numbers were pulled directly out of someone's record.
Sure. And we talked about that on last week's show, that this documentation could be a court record that you're going to have to go back to.
Yeah, and you know, AgProp is the first cog in the best practices, and documenting what you saw well, and that's another thing is a great many assessments are done fairly well, but if you weren't in the ambulance watching it, you wouldn't know that from reading the report. And there are different schools of thought on that. You know, you read nurses' notes these days and ER intake forms. They mainly do negative charting. They don't chart anything unless there is a finding, and it's supposedly assumed that every other finding is normal. And I don't necessarily agree with that. You know, I think if you're going to take a history and assess, you document your pertinent positives and your pertinent negatives, and put that story in context to that drop down list or that check box that you checked off. That's your chance to tell the story, and very few EMS personnel do a good job of it. What are your some of your best practices you think we should be doing?
Well, one of the things that I think, you know, back in the old days, I had the opportunity to sit on the AMLS committee and teach the AMLS course. And I believe,
first time I'm
yeah,
in the AMLS course.
I remember in Vegas. Yeah.
Yeah.
And one of the things that I believe in is the differential diagnosis cascade that they talk about in AMLS. And if you've not taken an AMLS course, I mean, it really is worth the money, because it really does kind of open your eyes to the opportunities of what else. And so my best practice has always been to talk myself into the diagnosis rather than say that this is what the diagnosis is. So I would really kind of start off with saying, what else could this be besides abdominal pain? And I had to talk myself into whatever the abdominal pain was going to be, gastric reflux, gallstone, whatever it was. And you know, from there, it would give me the opportunity to say, well, this could be cardiac in nature. Let me check the cardiovascular system. This could be pulmonary in nature. Nope, everything's fine there. Everything's fine there. Okay, let's go back to the abdomen. So for me, it was always to talk myself or prove the diagnosis that I was thinking more than this accept the diagnosis. I got bit in the butt one time really bad. And I was probably a paramedic at the time, maybe 10 or 15 years, where I went into a rehab hospital and the lady was in there for knee surgery, and the doctor was there and she was having a stroke, and
Yeah.
she had weakness, she was drooling, she had an IV in place, and I was going 3 miles to take her to the hospital. So I went ahead and did a quick assessment. I took her to the hospital. And then, long story short, I went back in a couple hours later. Her blood sugar was 27. They gave her insulin that was meant for the patient who was next to her. And they gave her the insulin, which bottomed out her blood sugar. So, but knowing better, without the diagnosis of the doctor telling me that she's having a stroke, I would have checked her blood sugar. I would have done all those things. So my failure was relying on somebody else's medicine and not using my own medicine to find out where we were. So this really kind of gave me the lesson, the embarrassing lesson as a cocky paramedic to say, you know, and I might not be as smart as I think I am, and I need to now talk myself into what I think it is rather than just assume that this is what it is. So, but you know, Kelly, I think we've come up with a lot of great tips. You know, we've kind of talked about
Yeah.
the importance, we've kind of give some best practices, but give your final thought and let's go ahead and go for the week.
Yeah, and my final thought is how difficult it is to improve the art of assessment and your skills if you don't get feedback. And that's a major problem in our profession. You had a doctor tell you that patient was hypoglycemic, but how often have we brought a patient in, we don't hear anything else about them. We get no feedback whatsoever on how to polish, and we, thus don't have the opportunity to polish our skills, polish our assessment, and increase our knowledge base. But hey, that's what I think. We've heard what Chris thinks. We'd like to hear what you think. What do you think your best practices are for patient assessment and documentation? We'd like to hear your thoughts at the show at ems1.com. Don't forget to rate us on iTunes. Follow our YouTube channel. And for myself and co-host Chris Cebollero, whose beard is starting to look a little scruffy, thanks for tuning in to Inside EMS. We're going to catch you guys next week.